Good evening, everyone. I'm Jack Deeby, Assistant Superintendent for the Avon Lake City Schools. I'd like to welcome you this evening to our COVID-19 Community Forum. We are not only live on Zoom, but we are also broadcasting live on YouTube. And I can see that we are actually successfully broadcasting on YouTube, as it's already showing me there are people watching on YouTube. So this video is being taped. This meeting is being taped and will be available for you to view. There will be a link on the Avon Lake City Schools webpage to the video posted sometime tomorrow. I know many of you have already submitted questions ahead of time. If you have questions that you would like to submit during the meeting for our expert, Dr. Remy, to answer, you can send those to me, feedback@avonlakecityschools.org. Please know that we are focusing on issues related to the science of COVID-19. We are not answering questions this evening regarding school procedures or any political or personal questions related to COVID-19. Dr. Remy has also seen the 50-some questions that were submitted ahead of time, and a lot of the answers to those questions you'll see coming up in his presentation. For now, though, I'm going to turn it over to our Superintendent of Schools, Mr. Bob Scott.
Thank you, Jack. And I'd like to start off by thanking Jack for being our facilitator. He's wonderful at that particular job and will keep us moving in the right direction. I'd also like to recognize Mr. Jim Stobie, who's our board president. I'm looking down the list. I see Pam Orzansky, who is a school board member. Thank you for being here all. We're so lucky to have Dr. Kenneth Remy here with us this evening. Dr. Remy has graciously agreed to share his knowledge with us tonight as an expert in the COVID field and as a member of the Avon Lake community. We appreciate him taking his valuable time to do this presentation and to answer our questions. I want you to know as we're going through this that Dr. Remy is associated with a local hospital and a university, but he's not representing them tonight. He's representing Avon Lake and himself as an expert. So we really appreciate his time. Dr. Remy is one of a group of experts who are vital to our decision-making process here at Avon Lake on our safety protocols. Our objectives have not changed since March of 2020. We want to make our school environment as safe as possible for our staff and our students. And we want to keep our kids in school every day with their teachers and with their peers. We have dealt with thousands of issues in the last 20 months, and I'm so proud of our students, staff, and families. Everyone has worked so hard throughout this pandemic. From the very beginning of this crisis, the ever-changing landscape of COVID has been our biggest issue. As we navigate the start of this school year, we know that we will have to make adjustments, and we'll have to do that on the go. We always like to be able to plan and inform people well ahead of time when a change is going to be made. But the nature of the times we're living in, sometimes that's not possible. But we'll do everything we can to make sure that you know what is going on as soon as possible. With that, I'd like to hand the program over to Dr. Kenneth Remy. I'll let him tell us about himself. So Dr. Remy, thank you for being here again.
Thank you for having me. Thank you. So for the folks I've not met, so we moved here about 2 months ago. So if you're trying to search who I am, I did in fact come from the University, Washington University in St. Louis. I'm an adult and pediatric critical care doctor. Previously at WashU, before that was at the National Institutes of Health. I have a laboratory that studies immunologic effects of sepsis and COVID. I do a fair amount of global health. Since the pandemic started, I've taken care of now over 2,000 direct patient contacts by myself with our team in Missouri, as well as now here in Cleveland at Rainbow Babies and at University Hospitals. As mentioned, I certainly represent myself as a concerned parent always, and I'm happy to be part of this community, and my wife is from this area. So I was recruited here to open up my host immune response laboratory and frankly, to become the Director of Critical Care Research for the Adults and Kids ICU programs at Case and University Hospitals in Rainbow. So I'm happy to be here. I sit on a lot of different task forces with both the FDA, the NIH, the WHO. I serve on a number of local task forces. Since this pandemic has started, a fundamental issue for me is keeping kids in school and keeping businesses open, and trying to find good scientific ways that we can make sure that we provide that level of evidence to do both of those, I think is vitally important, and I'm happy to talk today. So I had the privilege of going through a number of different questions. I think I just answered the first one, which is how come we couldn't get a local expert? Well, I am a local expert now, so thankfully, and I just literally got off an international conference where I presented on COVID, but I assure you I am sitting in 44012. And when I was married, even though I'm from New York 10 years ago, I believe at our, we had Shorty Shorman come to our rehearsal dinner. So I am quite ingrained with the Avon Lake tradition since my wife and her father and her mother both are graduates from many years ago. So I'm proud to be part of your community with my 4 children. So now I'm going to just share my slides. Just bear with me for 1 second. And what I hope to do is, see where we are. Okay. What I hope to do is answer your questions, at least that were submitted. And for those that I haven't answered, please, by all means, please give those to Superintendent DB so that we can answer those. And, you know, as a member of this community, you know, I'm happy to participate in these as many times as needed. One of the fundamental problems, let me just make sure you can see that. Are you seeing this big slide? Perfect. So one of the big issues, unfortunately, with COVID, as a lot of other things, is misinformation. And at least I'm hopeful tonight that I could provide you with the best level of at least scientific understanding of a number of different key questions. And also, I should mention I have no financial disclosures. No one's paying me for being here tonight. So we're going to talk a little bit about the current trends in viral transmission, some of the treatments, schools, and how this relates to SARS-CoV-2 or COVID-19, as most folks know it. Some of the information about vaccine, because there's a number of questions related to that and viral strains. So, you know, I can imagine that in making decisions, because one of the previous jobs I had in St. Louis was I was an elected official for a city. Thankfully, it's a non-denominational position, if you will. There's no political parties attached to it. But these are a lot of the different questions that came up with as kids were getting ready to go back to school, is weighing the different issues between public health and reason and sort of balancing, you know, a lot of the fear when we first started this pandemic that continues to ensue, and how we could best treat and help our kids. And a lot of the protective measures that certainly we undertook in the beginning, and we certainly are taking with all of these different surges, are meant to try to improve our healthcare system, which has a capacity. And so without that protective measures, being able to flatten that curve to a point that we can readily take care of those that are not just coming in with COVID, but are also coming in with myocardial infarctions or heart attacks or strokes, being able to get to people that need timely interventions are certainly inhibited by when we don't use protective measures. And so that's the concept of, in part, of flattening the curve, is that you don't exhaust the healthcare system to a point that you can't take care of not only patients that are coming in with that primary surge, but also a lot of the other things that are hopefully reversible and preventable. So if you look at the United States, and this was about 2 weeks ago, there's no difference today. The levels of community transmission of SARS, you can see that many parts of the United States are in red, which is high levels of community transmission. And if you were to look today at Lorain County, you would see the same thing, that it's red. If you were to look at Ohio cases now since July the 11th, and you're looking at all cases, you can see there's been a steady climb of numbers of cases, and hospitalizations have increased. Now, I will say one thing, that we have undeniably increased substantially all the way back to numbers of January. Now, one of my frustrations with the media is that there's this constant comment that, and the numbers are the same as in January and in December. That is not true. We're not actually at that same level, thankfully, but the numbers are higher than they were at the very end of that wave, if you will. And that's really the part of accuracy I think is more important to know, that we have had little blips in April, but the current blip that we're seeing has been continually increasing. And unless we do something that's going to potentially change that trajectory, we are going to have ongoing issues at many hospitals with capacity problems and with this current surge. So if you look at kids, because that's why we're all here, we all have children in school. We want to keep our kids safe. We want to keep our kids healthy. And from what my wife can tell you, as I worked 73 days in the COVID ICU, taking care of almost a couple hundred patients, calling families in the middle of the night to let them know their loved ones have died, my wife will tell you that, Ken, your job was absolutely horrible. But being home with 4 kids on virtual was not a picnic either. And so the ultimate goal is to keep kids in school. But if you look at the cases across the United States, and don't look at this downtrend here because this is actually an absence of numbers. This is just to make the graph. But this is where we are. We have increased for kids 0 to 4 through 12, all the way up to 15. The numbers of cases in children in the United States have steadily climbed since July. And this can be seen both in the MMWR and in the CDC data. If you look at hospitalizations, and this is 0 to 4 and 5 to 17, you can see a steady climb in hospitalizations of children. And I know that locally we've been seeing the same phenomenon with COVID disease. So children do get COVID disease. Children younger than 18 actually account for less than 2% of hospitalizations, thankfully. We've seen now with hospitalizations, 3,600 kids with 420 deaths. Now that's just one aspect of COVID, because as of July 2021, there's also been an additional 4,400 cases of what we call multi-inflammatory systemic syndrome, or MIC, which includes an additional 37 deaths. And this is a post-inflammatory response to kids that have had acute COVID disease. If you look at the numbers totally in the United States since the initiation of our first case at the end of January of 2020, January 22nd, I believe, there's over 5 million total children have been reported, which represents about 15.1% of all cases. But although children thankfully make up our lowest proportion of those being hospitalized in those cases, the proportion of COVID-19 cases is certainly growing with Delta. There was a question about what the percentage of Delta is. The percentage of Delta now is well greater than 99% of all the cases we're currently seeing in this region, as well as in the United States. We've not seen any substantial change in that when it overtook B117 or Alpha many months ago, approximately 7 weeks ago. So if you look at the proportion of cases of COVID, this is what we're seeing as of up to date. And you can see the largest growing proportion group is the 10 to 19 range. If you look at deaths, this is 1 through 4, 15 through 24, 5 through 14, and under 1 year of age. Don't go by this, it's not decreasing. I know that always looks funny to people who don't understand that that's how you make these graphs, but this is the increase that we've been seeing. So we have seen an actual uptick of deaths, and this is going to be updated in the next couple of weeks because we've certainly seen children with COVID disease have other viruses with COVID that certainly make them susceptible to an increased mortality. So what do we know about children and coronavirus transmission? It accounts now for 7% of COVID-19, 1% of hospitalizations, and less than 1% of COVID-19 deaths. This is the most accurate data now. The previous slide I showed you was pre-Delta. So this is the big threat that we're seeing. And this is not just locally, but this is nationally. Respiratory syncytial virus, or RSV. Many of you, when your children were very young, were worried about RSV bronchiolitis and being hospitalized. And as you can see here, the percent positive over the past 6 weeks has gone dramatically up. And as one can imagine, as this increases, kids also are susceptible to getting a secondary infection. And it's difficult to tell, but they either have COVID first and then RSV, or they have RSV then COVID. But certainly they're all becoming hospitalized with an increased severity of illness. Okay, so nonetheless, we still know that children seem to be less susceptible to adults. The infection rate, when you look at household exposures, seemingly is lower from children to adults rather than adults to children. So why don't children get as sick as their adult counterparts? Well, we don't completely know the answer to that. One idea is that children have a very robust immune system that can respond immediately with a lot of what we call the immune effector cells to these sorts of viruses that enter. Another idea is that older people have sluggish or paralyzed cells. Just like when my child goes out and runs a mile, he doesn't think twice about it and he's right up and running. For me, it takes about 10 minutes for me to get up off my chair sometimes to go run that mile, and I'm exhausted afterwards. And I certainly don't have that same recovery. And your immune cells that deal with acquisition of virus and control of viral replication, certainly as you age, certainly have some consideration for senescence. The other idea is that the receptor that allows for this virus to enter into the body has different expression. It's also possible that there are preconditions by other viruses that may have cross-reactivity with the ACE receptor, meaning if you just had an infection with that signals through this receptor, it's certainly possible you may not, as a child, get as much COVID. Now, we thought that earlier in the disease pandemic. We're not sure that that's true anymore because we've seen a paucity of a lot of these other viruses. And then also the respiratory tract of a young child certainly is different in anatomy than an older person's. And so that may change the actual viral load. So this is a picture of what the spike protein COVID virus looks like. And as it enters into your nasal passage and enters through, there's your ACE receptor attaches and allows for this to internalize. And we know that this receptor expression by its genetics has lower expression in 4 to 9-year-olds. It's higher in 10, 15-year-olds as compared to that lower age group. And this was the sentinel study that was done with looking at the noses of different age groups. And this is done in JAMA in 2020. And you can see those under the age of 10 certainly have less of those receptors, meaning they're not bringing as much virus into the body. And this is just another examination of that. So what do we know about who's at increased risk for COVID infection? Those with genetic conditions, neurologic conditions, these are your vulnerable population. Someone asked, who is a vulnerable? This is your vulnerable population. Because if I look at the 20 and 30 and 40-year-old patients of mine that have unfortunately died from this disease, invariably they had obesity and diabetes or hypertension. That's it. I mean, healthy, otherwise people who don't go home to their families had these unfortunate comorbidities. And there's some genetic predisposition to that, which is probably out of the scope of our talk for today. So besides the impact on health for kids and for the general community, undeniably, there are educational impacts of COVID pandemic, whether that's going to school or staying at home. So let's look at the learning lost during the 2020-2021 school year. So you're looking at, this was from McKinsey and Company, and you can see it is a significant impact to have kids at home, even utilizing virtual learning. So keeping kids in school across multiple demographics is important. And this is important data, I think, because it highlights that. If you look at the number of emergency room visits from mental health during these are the weeks during our COVID pandemic, you can see 2019 pre-pandemic, 2020 post-pandemic. A lot of mental health related to children either not getting the resources they need or because they're confined at home. And so therefore getting kids out of their home safely into schools is what I'm most importantly interested in. So let's look at school data. So studies have been done multiple times, and they continue to show that schools which reopened with mitigation strategies in place have seen little transmission in schools. So compared to that, with children who tested negative for the virus that causes COVID-19, children who did test positive were more likely to attend gatherings such as weddings, parties, funerals, and play dates without mitigation strategies, rather than attending childcare or a school in person. So this is a great study. This was done in Wood County. And this was evaluating the numbers of cases when mask wearing, distancing, people want to have a mask study to look at. This is a phenomenal one because this is directly done in Wisconsin. And this was done looking from August 31st through November 23rd of last year. And this is done with masking in place. And if you can see the total number of cases in Wood County against the school districts and cases attributable to in-school spread, you probably can't even see it, but it's all the way down at the very bottom here. Because kids were masked and distancing was occurring, there was less associated transmission because of those mitigation strategies. So let's look at other studies that have been done. So incidence and secondary transmission of COVID disease in schools. North Carolina Public Schools, fall of 2020. 11 school districts. They were in person for 9 weeks with over 90,000 children. In this, there were 773 community-acquired cases and only 32 school-associated. There was no child-to-adult transmission. And the number one cause for those 32 was absent face coverings. And greater than 3,000 students had a quarantine, which, if you think about it, those kids are not going to school because they had a quarantine because of exposures. And so this is why it's so important to maintain these mitigation strategies at the present time. I'm hoping someday soon we'll get away from this. This also was done in Massachusetts public schools. This is looking at 3 feet versus 6 feet. And you can see this is transmission and numbers of cases in these public schools, almost a little under 540,000 students and 100,000 staff. And you're seeing here the case rate for 3 feet for student and staff. And you can see here that staff undeniably have higher caseloads than kids. But there's no major difference between 3 feet versus 6 feet for children, and very little difference between adults from 3 to 6 feet. And so this and a number of studies have allowed us to be able to move that 6 feet to 3 feet radius and allow our desks to be set up in one classroom rather than spread out among multiple classrooms when possible. This is another pilot that was conducted in Springfield, Missouri and St. Louis County. Now 21,000 students receiving in-person schooling. And during that school year, 56 cases happened with attending in school. Obviously, the higher number is close contacts, non-school related transmission when masks and distancing and ventilation and good hand hygiene were maintained. And then certainly the CDC has modified their 6 to 3 feet now and have recommended across the board that kids K through 12 are masked and maintain these precautions presently. And these mitigation strategies, as already known, are mask wearing, social distancing with 3 feet, hand hygiene frequently throughout the day, and good ventilation symptoms, and awareness based off of symptoms of when people need to self-quarantine. And as many of you have seen these sorts of things, these are your general symptoms: fever, congestion, runny nose, nausea, vomiting, diarrhea, sore throat, headache, fatigue. And then if you've got a cough, difficulty breathing, or loss of smell. So vaccination, undeniably, when you vaccinate adults, it results in a reduced transmission, especially among kids. And when you look at the effective mitigation strategy in Philadelphia, once we were able to get vaccination in this previous spring, you can see that only 0.09% tested positive after full vaccination as compared to unvaccinated. And remember, this is only a couple months because this was really only available when we started in most places in March and April and May, towards the end of school. So where are we with vaccination with children? So Pfizer lists their expanded access to vaccinations, and now recently FDA approval for children above the age of 12 years. And studies in younger children are ongoing. And I am optimistic that we will have vaccines in younger children this fall, because a number of studies that I've been a part of have been conducted and are almost ready to conclude shortly in children, to get to the point that we'll be able to get vaccine in children that parents decide is important. So let's look at vaccination effectiveness in the real world. So if you look at this, and so you see vaccination, and you see all these different options here with what happens to changes of infection. It drops to 1 to 100. You have a 95% reduction in chance of infection. Now, to be clear, with 2 doses of the vaccine, you can still get COVID, but you are less than 2.5 times likely of having symptoms And certainly, and it's about 88% of people that have a COVID vaccine will have zero symptoms. So it's a small cohort that will have any symptom at all. You certainly can spread the virus potentially, but you're also more likely to not become hospitalized. And that's what the effectiveness is. It's not that you're going to die from COVID. It's that you're never going to have to become hospitalized. It's just like influenza. It's trying to decrease death, decrease hospitalization, and decrease missed days of work. And that's what the effectiveness of influenza vaccine is. And similarly, that's the hope for COVID vaccine. And you can see these are the numbers of how effective it actually is as we've looked at over the past couple months, even with Delta. So a number of questions have come in related to your ability to fight off the disease and what your viral load looks like. And so in patients that are vaccinated, that get exposed to COVID, they actually have a 40% lower viral RNA load in vaccinated cases, a shorter duration of the disease, and a shorter duration of illness. They also have a decreased chance of getting fever. Like I said, you can still get the virus. It's less common. It's not going to be as severe. And quite frankly, this is what I expect the new norm is going to be for this as we move forward to getting a higher vaccination rate so that then everyone goes on in their merry way. And so here's the vaccination, what happens with those that with prior infection, because this is a common question. Well, if I've had the disease, I don't need to get a vaccine. Well, that's not true. This has been looked at a number of times, including this Kavanaugh MMWR, which demonstrates that there is 2.34 times lower risk of reinfection compared to those that were unvaccinated. And when you look at those that have had an infection versus that have had vaccination versus no vaccination, those that have no vaccination have a higher incidence of severity of illness, hospitalization, and in our adult population, unfortunately, death. The viral variants. So diseases like this, they constantly change through mutations. So when we first started, we had one mutation. It then mutated to something called D614G. That one was not nearly as severe as the first wave. We continue with D614G likely to the fall. Then the B117 variant started to come out. That's when we had our biggest peak of this entire pandemic, basically through November to January. We've continued with Alpha variant as being the predominant strain. And then certainly over the past month and a half, we've now moved almost exclusively now to Delta. Some variants actually are less virulent, meaning you won't get the disease as easily. And more importantly, hopefully you might have less severity of illness. Other variants have the opposite effect. This is what the numbers look like now across the United States. And what you're looking at here is B1617.2. This is Delta. And at the very tip, this is about over 99%. You're starting to look at the other small variants. But this is what's happened now since May. And as you can see, that variant clearly took over the United States, maybe more transmissible and has an increased risk of severity of illness. So are your vaccines effective against this variant? So after one dose with the Pfizer, you've got about a little under 40% protection against becoming symptomatic. That's the effectiveness here. It's not death. It's not anything more than just becoming symptomatic. But after your second dose, you're sitting in and around about 88% for Delta. And then with the Alpha variant, it was a little bit higher. The AstraZeneca is not nearly as strong, or I should say as potent against Delta as certainly we see with Pfizer. And then these are the effects over time. This is 209 days out for protection. These are your antibody titers that far out. And as you can see, you've got pretty good protection from the point of your second dose all the way throughout 209 days. Natural immunity does not give you these results because it wanes typically between 3 and 6 months, and it all is incumbent upon the inoculum you received. If you got a huge inoculum, you may have a large antibody response. Whereas with a vaccine, you get a carefully known dose of the virus of an mRNA version that's created. It's not a live virus, obviously, but it tricks your body to believe that it's now seen the spike protein. So when it gets exposed to this, it can jump into action, if you will, and use correct cells that could then fight off this infection. I'm simplistically explaining this, but this is different than natural immunity. Natural immunity, you don't know those because some people get a severe illness, others don't. And so their antibody response is certainly attenuated as compared to others, depending on that initial inoculum. This is against COVID infection against frontline workers. And you can see these are infection. So up to 119 days, 85% of people that are working with COVID, they're in, every day I go to work and I'm taking care of COVID patients like I did last week. I'm with COVID. I'm intubating patients with COVID. I'm getting potentially droplets in and around the air that is around me and my mask and my gown. And 85% is how strong that effectiveness is. That's pretty good for that far out, 119 days. Okay, so just going into by vaccination strategy and status, you can see here, and this is well described throughout much of the public, the media. Infection is 4.9 times more likely in the unvaccinated. Hospitalization is almost 30 times more likely in the unvaccinated. And then death among those who are unvaccinated associated usually with a medical condition and or advanced age. But an underlying medical condition could be a 35-year-old with diabetes and morbid obesity. And unfortunately, that's what I've seen too much of. So people have asked about boosters. The current recommendation is that a third dose of the mRNA vaccine is going to be recommended. This is still getting worked out right now. And it's going to be approximately 8 months after your last dose. That's when we're hoping on the 20th of this month, the recommendation is, because we think that that's the time where you start to dip down with your antibodies. Okay, so this is a simplistic, although not too simplistic, picture of looking at what happens when you have a high community vaccination and the effect of transmission in schools. So someone asked a great question. He said, are we ever going to get rid of this pandemic? And the truth is, I 100% believe we will. I think we're going to eventually shed masks and we're going to be able to not have 3 feet between our children. But the key is going to be vaccinations, because that is going to reduce community spread. We know that across the board, states that have and locales that have the highest vaccination rates, well above 75%, have the slowest and reduced transmission of even Delta. And I would suspect that we will get there, hopefully, when children under the age of 12 can also get vaccinated safely. So this is just something, it's an older slide that I've had because this question comes up frequently. Does COVID live on surfaces? This was a study that was in New England Journal of Medicine back last year. It compared copper, cardboard, stainless steel, and plastic. It looked at the first COVID disease back in 2003-04 against the current COVID-2 or COVID-19 disease. And what you're looking at here is duration that this can live on surfaces. And undeniably, after 24 hours, it is unlikely that copper and cardboard keep the virus on surfaces. These are untouched surfaces without any cleaning products. It can certainly last a little bit longer in plastic, and after 48 hours, it dissipates. And this is what happens with UV light. And so this is COVID-1, and COVID-2 we suspect has similar reaction to UV light. It's very sensitive to it. But I wouldn't light yourself up with a UV light because it's not going to move internally to kill the virus that you have inside you. Okay, so key questions that always come up are mask wearing, hand hygiene, appropriate distancing. I think we went through some of those. Does age of students matter? Staff interaction, measurement of fever, how to deal with symptoms. I'm happy to answer a lot of these questions. When we look at opening schools, we think about 3 different risk levels. The lowest risk, which are students and teachers engaging in virtual only classes. More risk and the highest risk, which are full-sized. Everyone goes to school and participates in activities. That's where we are currently at most schools. And this is where I would encourage us to stay with the appropriate reduction. So if you looked in this is in Texas daycares, as well as in cases in Oregon. And this is no masking, no distancing. And this is when the community, like that's all red across the United States, has high numbers of cases. And as you can see, there is a substantial increase in children that receive the COVID disease because of the lack of mitigation strategies. But if you compare that to, for instance, daycare in the greater northeast of the greater northern New Jersey and New York, YMCA's, 35,000 kids, masking, distancing, there was less than 10 cases. Mask type, this comes up a lot. So this is your chance of COVID transmission based off the following: physical distancing, face masks, and eye protection. So eye protection is not commonly prescribed or is not recommended just because it's too onerous at this point. And frankly, these other strategies are fantastic. And the probability, if you have no mask and somebody is wearing a mask, that you will transmit is approximately 70% if you're a carrier. If that person is wearing a mask, but the other person's not wearing a mask, the chance of probability of transmission is only 5%. And if both people wear masks, the transmission probability is 1.5%. This has been demonstrated now in multiple studies. Now, there's multiple types of masks, surgical masks, cloth masks. It creates a barrier. Everyone always says, well, the micron size specifically of this virus is smaller than the pores that are in your mask. But if you think about it, if you were to take a piece of screened-in porch and you were to just take that and put on the other side a paper towel, and you would shoot a water gun and quick in a spray fashion, not a direct, but a spray fashion, and then on the other side saw how much moisture was going to be on that paper towel, it would actually be blocked because there is a barrier to that occurring. Take away that piece of screen and just have directly the spray and your paper towel, and your paper towel will be wet. That is why they work. They reduce the amount of inoculum. They're not perfect, but they are certainly beneficial and helpful. And so I'm not going to talk about this. This is just different types of breathing and filtration rating based off of which ones are better. This talks about exactly the same thing I was talking about size of the droplet and the distance that's been recommended. Certainly, these are the different filtrations. For kids that are in school, I would always recommend that because kids have been wearing these now for over a year. Certainly, if you're continually wearing them during school and you don't get a mask break, protect those ears, because that's one of the big things we see. Okay, this comes up all the time. Do masks decrease or increase carbon dioxide levels or decrease my oxygen levels? Well, there have been a lot of studies that have specifically looked at just this. And every one of them that have been done in a rigorous scientific fashion have demonstrated that surgical masks do not elevate your CO2 levels to dangerous levels. In fact, your CO2 bubbles are far smaller than COVID, and so they're not even trapped in your mask. And so if that were the case, then obviously multiple surgeons and folks like myself in the intensive care unit would be falling left and right from carbon dioxide narcosis, and we don't see that. Steve Shine at Rainbow Babies and Children's, one of my colleagues, did an excellent study that was published this past year. And he did this with wearing a mask, a regular surgical mask, nothing fancier, just a surgical mask you can get from Walmart. And he looked at 50 healthy volunteers and looked at what happens to their heart rate, their carbon dioxide level, and their oxygen saturations by wearing the surgical, cloth, or baseline no mask. And at rest, there was no difference. When he put those same people through physical activity, there was no difference. This is a well-done study that shows no statistical difference between the groups. And then we also published this in CHEST, and I know it's a little bit hard to read here, but we looked at pre-COVID, post-COVID, just with measures such as masks among children with the common diseases we see in the pediatric intensive care unit. And what you see in red is pre-COVID, blue is post-COVID. And what you can see is asthma, bronchiolitis, pneumonia, all were drastically reduced with COVID and during the COVID era. And that's not because, because people didn't perhaps, it's because they were using mitigation strategies like mask wearing. And if I still haven't convinced you, here's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15 studies that have scientifically demonstrated reduction in disease transmission by wearing a mask. So I think we can all do this by staying home when we're sick. We practice social distancing, limiting our crowds, washing our hands, wearing our face covers, and we're part of the same community. And the goal is to help one another to get through this horrible pandemic, which I think we're going to see that light of the tunnel when we can increase vaccination among our adults and those greater than age 12. And then hopefully those under the age of 12 when it's available. And I will gladly give my children that vaccine when it becomes approved for expanded access protocol and then FDA approval after that. So a question was, do I see any potential for it to become less widespread? Yes, this is the key. This is the state of Ohio as of last week. Since January 1st of 2021, you're looking at the total hospitalizations. This is among those who are not fully vaccinated. This is among those that are fully vaccinated. This is in the era of Delta. That's staggering. That tells everything that, the best way to prevent getting yourself or others around, especially if they're immune compromised and can't get a vaccine, you get vaccinated. And it is the disease of the unvaccinated. And so you're looking at the numbers of beds, and these are vaccinated folks, these are unvaccinated. And this is what I see day in and day out in the intensive care unit. Younger people, 30s, 40s, 50s, and certainly obviously over the age of 70. So question about vaccination. So Pfizer has the approval for above or equal to 12, and we're hopeful that it'll become this fall. As everyone knows, currently there have been a number of adolescents that have been studied, 2,260 participants in the initial study. And what we saw in those that received vaccine that were teenagers, no infections, 16 infections in those that were in the placebo group, and they had the same immune response profile as we see with older subjects, with very little side effects. This is a big question because everyone is very nervous, as I would be as well, with the potential side effects. These are what gets reported. We've got over 300 million now doses that have been delivered, and the most common are injection, fatigue, headache, myalgias, chills, in both of them. I get asked frequently, well, what about the long-term effects? Truthfully, over the last 85 years of vaccines, and we've been studying mRNA. I was at the NIH, they were studying mRNA vaccines then too. You're going to see over 99% of all side effects within the first 45 days up to 60 days. Vaccines do not typically have a long-term side effect profile. If you're going to develop, let's say, Guillain-Barré, those are seen within that first 45 or 60 days. And so I have no anticipation that there is going to be any quote unquote short, longer term effects, because we just haven't even seen it yet. And we've been giving out vaccines now for at least 9 months, and we've not even seen that. Now, myocarditis comes up a lot. So myocarditis is inflammation of your heart muscle. And there was a concern by reported cases in the VAERS, which is the vaccine adverse effects response. And anything that happens that could be related to a vaccine gets reported. So if I were going to call tomorrow and say that I got the COVID vaccine today and my hair is blue, even though my hair is not blue, but I called and said my hair was blue, they have to actually document that. So with myocarditis, there were approximately 1,200 cases that were reported. There were actually defined 320 among general patients between 12 and 29 years of age that were hospitalized, 0 deaths. Contrast that to COVID, and just by acute COVID, there's been not only more deaths, more hospitalizations, more ICU admissions, and then we know now from MISC, which is that post-inflammatory, we've now seen a couple hundred deaths. And so the disease itself can cause myocarditis. Kids can get myocarditis from other causes. It's unknown whether it's a direct phenomenon in such a small number of cases now, 326 out of thousands of vaccine. And thankfully, every child that had myocarditis phenomenon stayed in the hospital and went home. And so we do believe that the COVID-19 disease is far worse than any sort of side effect that's thus been seen so far with vaccinations. And risk of myocarditis is exceedingly low. In fact, if you looked at non-COVID disease, you would see myocarditis spontaneously in the community. And there's just a reiteration of what I just had said. This is long COVID. This is kids getting COVID and having long-term effects from COVID. It's not just as simple as they lived. There are, in fact, long hauler or long COVID symptoms that we are now seeing over a year in children, including this MISC phenomenon. And so this is one of the reasons why I'm so adamant about trying to find ways to prevent kids getting it from the first place, which is my ultimate hope until we can get to the point that the numbers are so low in the community that spread is going to be virtually exceedingly low. And then there was a question about ivermectin. I didn't include it in here, but there is now well over 17 published studies on ivermectin. Listen, if ivermectin works, I'm going to be all for it. The data just does not support it in randomized control trials. There is some signal in small studies that are not as rigorously performed that there could be a benefit. There's a side effect profile that perhaps is not it's not as favorable as other drugs, such as using a steroid like dexamethasone for a short period of time. And frankly, the data that's come out of a number of different larger trials has just not been, unfortunately, helpful. So that is a long-winded way, if you will, for me to at least go through a number of different topics in a rapid sprint. And I am sure that this group of folks probably has lots of questions, and I'm happy to take any of them.
And if anyone has a question, please email them to feedback@avonlakecityschools.org. And Dr. Remy, I'm going to jump on just a couple of questions that have already been submitted.
Okay.
The first one asks about antibodies. Is there a difference in the time length of antibodies that develop naturally in your body versus those that come through the vaccine?
Yes. And so I think I showed the figure of what it looks like up to 119 days if you receive the vaccination. And we do not believe that you maintain that same level of immunity just by natural infection. Secondarily, what proves that point is that people who have had COVID get vaccine versus people who have had COVID and don't get vaccinated. There's a much higher incidence among the unvaccinated group. So clearly your natural immunity is ineffective in allowing you to get that sick as compared to the vaccinated group. Now, I said earlier, and I've said it a few times, that you can still get the virus with vaccination, but the degree for how often and how sick you are in the unvaccinated population is staggering. And so you could have had the disease many months ago or a year ago. You likely do not have effective an infective immune or antibody response to the disease.
And following up on that, there was a question about how often is someone going to need to get the booster shot?
Short answer is we don't know. I can hazard a guess and tell you that my thought would be that we're probably going to be on a schedule of, I would assume, a booster annually. But I don't know that we know that yet, because as it sits, we've got data now for about 8 months. We suspect that after 8 months, that's when people would get their booster. And quite honestly, we'll have to follow people's titers and follow the disease transmission from that point to decipher if people will need another booster at some point, or if they're going to have lifelong immunity. I suspect the latter is going to be not true.
There was a question about knowing the percentage of positive COVID-19 individuals who become symptomatic. And I know you touched on that. Could you just give a little bit of a refresh on that?
The percentage of people who become symptomatic, meaning they have the disease and
yes,
they're asymptomatic, and which I don't know the answer to that. I think that's really difficult, because that would assume then, so if you were to test everyone every single day or within intervals, that would allow you to see who's got a positive PCR test against who becomes symptomatic. It might be possible. I don't know that answer offhand, to be honest with you, so I don't want to hazard a guess.
There are a couple questions that were submitted referencing a CDC study in Georgia that claimed that there was lower incidence, that the mask usage was not significantly statistic compared to schools where it was optional. And I know the data that you showed was the exact opposite of that. Could you elaborate on that situation?
Yeah, give me 1 second, actually. I'm going to pull up the exact thing that's being referenced, because there may be some difference in what is thought to be. Okay, so. Okay, so are you able to see this?
Yes.
Great. And so this is the exact thing that was referenced. And this is mask use and ventilation improvements to reduce COVID-19. This is from Georgia, November 16th through December. And in fact, actually what they found was that COVID incidence was 37% lower in schools that required teachers and staff members to use masks, and 39% lower in schools that improved ventilation. That's the actual study.
Great.
It actually has a benefit. It demonstrated a benefit.
The next question, this is probably somebody from a medical field because I really don't know what this is asking, but it says most of your data was on mRNA vaccines. Is there similar data available on viral vector vaccines?
Yeah, it's not nearly as robust because Pfizer and certainly the Moderna vaccines have been the predominant one. We do have some data with Johnson & Johnson. In response to your question about viral vectors, so I was on a call today where we talked specifically about adenovirus viral vectors and whether or not that has an improvement in perhaps outcomes with the current Delta variant. That data is going to be released soon. It's not as optimistic as one had hoped.
Great. Several questions on passing along COVID, and generally the questions range from can an asymptomatic person pass on COVID to someone who ends up being symptomatic?
Yes.
Has there been any studies on potential negative impacts of long-term mask usage by kids?
So there have been, so as far as long-term effects, so I think the key thing is keeping kids in school rather than being at home. I think that there's been a number of psychology journal studies that have looked at the negative impact along mental illness. We also know that violence with keeping kids at home. Now, when you're talking about wearing a mask versus not wearing a mask, I am unaware of any controlled trial that specifically looked at that specific issue. I think, and this is anecdotal, and this is just me being a parent, not being a physician scientist. My kids, we came from Missouri where it was like 95 degrees, and my kids were wearing masks every single day in their schools, and I was wearing masks every single day. And I got to say that my kids got used to it, and most kids, at least that I interacted with, just got used to it. I think it's hard for us to get used to it because we don't want to be used to it. We're sick of this virus. We're fatigued, and we really want it to be over with. I think we're going to get there, that we can get rid of all of these masking questions, hopefully in the near future, if we can just get, the Lorain County vaccination rate from 53% or 65% to much higher, and we reduce transmission across the community. So the answer to your question is I'm unaware of a great study that I could tell you what the negative impacts of mask wearing are, but I can give you about 55 studies that tell you that at least it keeps the disease transmission much lower and keeps kids in school. And to me, that is vital.
There were a few questions about things such as vitamin D supplements or natural remedies. Do any of those things show effectiveness in reducing either obviously probably not getting COVID, but the severity of symptoms?
Yeah, vitamin D, vitamin zinc, vitamin C, unfortunately have not demonstrated, when compared in a randomized control trial, multiple times have not demonstrated benefit for treating COVID. Now, in preventing COVID, I think that there's something to be said about a good diet for anyone. And this is Northeast Ohio, where the sunlight perhaps is not nearly as strong as it is if you were living in Hawaii. And so I would say that, for any child, a healthy diet that includes milk or vitamin D and calcium, those are important cofactors for anyone for maintaining good health. So whether or not I would give my child, I would give them a multivitamin every day. I'm old, so Flintstones were what was in vogue in the late 70s, early 80s. There's nothing wrong with giving your child that. Whether that prevents, it's unclear. It's unlikely that it's got a dramatic impact if your child were to develop COVID. But I don't have a problem with it. It's just that there's no great data to support it as a prophylactic.
Have there been any studies linking increased chances of miscarriage or stillbirth or breathing issues in babies because of the vaccines?
That's a great question. So there's actually the ACOG and CDC's got a great webpage, and they actually delineate a lot of these questions about fertility, as well as questions that response to vaccines. I would love to refer anybody that's interested, just go to the CDC. They'll actually give you all of the different studies, and they'll also reference ACOG, which is the American College of Gynecologists and obstetricians. They mean to diminish their credentials.
And Dr. Remy, I'm going to touch just on two questions that,
Yeah.
although I said I wouldn't answer school questions, there are two that I think are worth pointing out. I've had a couple questions about where they can get tested, given the shortage of testings. We do have rapid test kits available at the district office and at Avon Lake High School office. If you are getting them, we will not let children take them home, but parents can call and arrange to pick one up either at the district office or at the Avon Lake High School office. And there was another question about if you do test positive for COVID right now through the ODH guidelines, anyone who is fully masked or fully vaccinated is not subject to quarantines. The question that I had a couple people ask was, what about people who test positive? And if you test positive for COVID, once you return from your 10-day isolation, you're exempt from quarantines for 90 days. It's not an indefinite exemption.
Superintendent, one question that I would just tell people is that Walgreens and a lot of other grocery stores now, they sell quick views. These are actually quite good. And in fact, at a lot of different universities, and we're actually using positive or negative tests as a good screening tool. So you can get 2 in a pack for $23. And I would suggest that if people are concerned and want around exposures, this is a good way to at least self-test at home and beat the lines if there's a huge line at testing at some of the health facilities. I would say that if you get a positive test, then you should follow up with your health provider.
Great.
And I say that one, sorry to interrupt you. I say that for another key reason. So if you are, 35, 40 years old, you're obese, you might have diabetes, and you become positive, you may be at high risk to actually become hospitalized at some point. And so we do have Regeneron monoclonal antibodies, which neutralize the ability for the virus to come into your body. And these are free. It's a single infusion, and you can go online to look at monoclonal antibody tracker by zip code, and they'll tell you where to go. But they reduce transmission, they reduce hospitalization substantially and decrease death. And so these tests are helpful because if you're positive, the one thing you don't want to, you want to go to your healthcare provider, but if you wait and get sicker and have to become hospitalized, you can't get that treatment anymore because that's not what the emergency access allows for. So this will prevent hospitalization. So if you do become positive, for moms and dads out there, I would recommend at least going and seeking a medical professional to try to get monoclonal antibodies. And both the Cleveland Clinic and university hospitals certainly have access to all of that readily available for all of the community.
Great. Dr. Remy, thank you. I'm going to turn it over to our superintendent, Bob Scott, for a couple closing comments.
I want to thank everybody for being with us, and Dr. Ken Remy again for doing this for us. It's a great resource for us. Probably, and Doc, you can jump in on this. You've talked about it a couple times, but people specifically keep asking me, okay, Bob, what are the numbers? What are you going to do? And when are we going to be able to not mask and not have social distancing and be back to normal? And it's almost an impossible question. We talk to experts like yourself, and we're not just looking at today in Lorain County, but we're looking inside the schools. And of course, when we have positive tests and quarantines, that forces us to look 10 days, 2 weeks down the road to decide where we're going to end up. Now, we're seeing really good results right now inside the schools, and especially since we went to masks, we're seeing good results. But we're going to make that decision when, again, we get back to that piece. Kids are stay safe, and we can stay in school every day with as many kids as possible. So we really do want to keep, with our younger kids, we are masking and the numbers are looking good. We're hoping to keep moving ahead. Our 7th through 12th graders, they are starting to self-control. They understand that if they're masked or vaccinated, they don't have to be quarantined, even if they are exposed. And I'll go back to a second piece and this is one of the first slides that you had. Our kids are at school 8 hours a day, and then sometimes they have after school activities. That piece is where our community needs to come in and help us. Where those kids are going, who are they exposed to, because then they're coming back into our classrooms. And that's a piece of our puzzle. How do we keep those, we know kids are going to get sick, but we don't want them to, but they are, that's just natural. But once that happens, we want to make sure that there's no spread, that we don't have those other kids inside the school that get sick. And we have to, to go to more stringent mitigation protocols like closing classrooms or closing schools. That's the worst thing. We can't do that. So thank you, everybody. Again, Dr. Remy, thank you for being with us. We've had a great start to the school year. Our kids are doing wonderfully. Everybody's working hard.
Thank you, everyone, for participating in our community forum this evening. Again, it'll be available for your review on our YouTube page, ALCS on YouTube, and there will be a link on the Avon Lake City Schools homepage sometime tomorrow. Have a great evening, everyone.